You know, usually when we talk about a cancer diagnosis, the imagery that immediately comes to mind is it's very cellular.
Right, yeah, like looking through a microscope.
Exactly. We picture the single rogue cell, and it mutates, and it starts dividing out of control to form a mass. We tend to view it strictly as this localized cellular disease.
Which is, the traditional view of oncology. For a long time, the focus was almost entirely on that unregulated cell growth and the specific genetics driving it.
Right. But then you step back, you look at how a tumor actually survives in the human body, and the picture just changes completely.
It really does.
Because to survive, right, to grow beyond just a tiny microscopic cluster, that tumor basically has to become a plumber. It has to completely hijack the body's vascular system.
Yeah, it is fundamentally a vascular disease.
And that is exactly what we are diving into today. Welcome to our deep dive into the absolute edge of oncovascular surgery. We're going to synthesize an incredible textbook called Vascular Surgery and Oncology, edited by Zarati, Nishinari, and Wolasker.
It's a fantastic resource.
It really is. And for you listening, whether you are a medical student, maybe a young surgical professional, or just a curious, self-taught learner, this is for you. Okay, let's unpack this. Because understanding this intersection of oncology and vascular surgery, it completely transforms how you approach patient care.
Definitely. And the goal today is to give you clear scientific explanations of both the biological why and the surgical how. We're going to keep it grounded, avoiding any unnecessary jargon so you can really grasp the mechanics of what's happening.
Awesome. So to understand how to actually operate on a cancer patient's blood vessels, I guess we first need to figure out why the tumor is interacting with those vessels at all.
Right. And that brings us to the legacy of Judah Folkman. He was a real pioneer in this field. He defined what we call the vascular phase of cancers.
Okay, the vascular phase.
Yeah, he demonstrated that a tumor literally cannot grow beyond maybe 2 to 3 millimeters unless it establishes a dedicated blood supply.
I mean, it makes sense. It needs oxygen and nutrients just like any other living tissue, right?
Exactly. And the tumor gets this in two main ways. First, it can just co-opt existing healthy blood vessels. So it essentially wraps itself around the native anatomy. Or, and this is the second way, it forces the body to build brand new ones.
Which is tumor angiogenesis.
You got it. The malignant mass releases these powerful chemical SOS signals into the surrounding microenvironment. And those signals, they essentially trick the nearby healthy endothelial cells into sprouting new blood vessels that grow directly toward the tumor.
The wild thing about this process, though, is that the tumor is demanding all these new blood vessels, but it's actually terrible at building them.
Oh, absolutely terrible.
It's like a corrupt city planner, throwing up these shoddy, unregulated roads overnight. The infrastructure is just a complete mess, causing constant power grid brownouts for the tumor itself.
That is a great analogy. The biological consequence of that tumor-induced angiogenesis is a highly dysfunctional vascular network. Because the tumor forces these vessels to grow at such an unnatural speed, they're structurally defective. I mean, they're leaky, they're tortuous and twisted, they lead to dead ends, they completely lack the normal, robust layers of healthy veins and arteries.
But wait, if the tumor is causing its own blood supply to be so dysfunctional, why doesn't it just starve itself out? Like, if the roads are that bad and the power is constantly failing, shouldn't the tumor just die?
That is the logical question, right? But if we connect this to the bigger picture, that harsh, chaotic environment is exactly what makes cancer so deadly.
Wait, really? How does it help it?
Because the blood flow is incredibly erratic, the cancer cells are exposed to this intermittent state of hypoxia, which is a severe lack of oxygen, followed by sudden rushing bursts of reoxygenation when the blood flow temporarily returns.
Oh, wow. So it's like a constant cycle of suffocation and then a flood of oxygen.
Exactly. And that cycle causes massive oxidative stress at a cellular level. It favors severe DNA damage, mutations, and it increases the genomic instability of the cancer cells.
So it's basically an evolutionary pressure cooker.
Yes. It forces the cells to rapidly mutate just to survive the harsh conditions they created. So only the most aggressive, resilient cancer cells survive. And since those vessels are so leaky and poorly formed, like literally missing tight junctions in the walls, it's incredibly easy for those hardened cancer cells to slip right into the systemic bloodstream.
Which is metastasis. That's how it spreads.
Exactly. And metastatic spread is ultimately the cause of 3 out of 4 cancer deaths.
So the tumor builds bad roads. The bad roads create stronger monsters, and then the monsters use those same bad roads to escape into the rest of the body.
That is a very grim but accurate way to put it, yeah. The local dysfunction creates a systemic catastrophe.
And because these vessels are so dysfunctional, the consequences don't just stay local. The tumor is constantly dumping cellular debris and procoagulant particles into this chaotic network, right?
Yes, constantly.
Which eventually dumps right into the main bloodstream. And that leads us to the clinical reality of clots and bleeds.
Right, and this is not a new discovery. Over 150 years ago, a French physician named Armand Trousseau identified this clinical link. He noticed that thrombophlebitis, so blood clots, was frequently a sign of a hidden visceral malignancy.
Trousseau's sign. It's crazy that a 150-year-old observation is still one of the most vital clinical warnings today.
It really is. The modern statistics are staggering. Up to 15% of cancer patients will experience clinical venous thromboembolism, or VTE.
And VTE includes deep vein thrombosis, right? DVT.
Yes, deep vein thrombosis, usually in the legs, and pulmonary embolism, or PE, where a clot travels into the lungs. 15% is a massive number when you consider the sheer volume of oncology patients.
Absolutely. And it varies heavily by cancer type, doesn't it?
It does. Lung cancer is actually the highest, associated with VTE at diagnosis in about 17% of cases. Then you have pancreas at 10%, colorectal and kidney both at 8%, and prostate at 7%.
So if you're listening to this and you're working in, say, an emergency department or primary care, this is a huge clinical application for you. If a patient comes in with a sudden, unexplainable DVT, no long flights, no recent surgery, you really need to pause.
Oh, absolutely.
That clot might actually precede a cancer diagnosis by months or even years. It's the body's early warning system sounding the alarm.
Exactly. The vascular complication is often the very first clinical manifestation. Before the tumor ever causes pain, it's already altered the patient's blood chemistry.
Okay, so we've established that cancer physically wraps around blood vessels. It alters them. It throws clots through them. So it's inevitable that when an oncology surgeon actually goes in to remove a tumor, they are going to hit some major vascular roadblocks.
It's unavoidable. But historically, that was a nearly insurmountable problem. I mean, if a tumor had invaded a major trunk artery, the cancer was often just deemed inoperable.
Yeah.
The risk of hemorrhage or causing a stroke was just way too high.
But then we started trying to solve it. I was reading in the book about 1953, the surgeon, J.J. Conley.
Yes, Conley. He published the first case series on arterial reconstructions for malignant cervical tumors.
So neck tumors invading the carotid artery.
Right. He operated on 10 patients, 8 with malignancies. And the early results were really tough. High complication rates, 3 graft occlusions where the new vessels just clotted off, 1 major rupture, and 3 deaths.
That is grim. But I mean, he was operating before modern synthetic grafts or advanced suturing, right?
Exactly. It was incredibly difficult early work, but it laid the foundation for oncovascular surgery to become a distinct, specialized field.
And the modern gold standard in that field today is something called en bloc resection, right?
Yes, en bloc resection is preferred because you do not try to meticulously peel the tumor off the invaded blood vessel.
Because if you try to scrape it away, you risk leaving microscopic cancer cells behind.
Right, or you rupture tumor capsule, which practically guarantees a local recurrence. So instead, you remove the tumor and the entire segment of the invaded blood vessel together as one solid block.
You just take the whole pipe out with it.
Exactly, to ensure clean oncological margins. And then the vascular surgeon steps in to reconstruct that missing section.
Okay, I have to push back on this, though. If a tumor has physically invaded a major trunk artery, say the aorta, isn't that a sign that the biology of the tumor is too aggressive and surgery is pointless? Hasn't it already spread everywhere?
It's a very intuitive assumption. But what's fascinating here is that the data, especially for soft tissue sarcomas, tells a different story. Vascular involvement is not necessarily a predictor of aggressive systemic biology.
Wait, really? So it's just a matter of geography?
Frequently, yes. The tumor simply grew into the path of least resistance and happened to bump into an artery. It doesn't mean it has the biological potential to establish micrometastases everywhere else.
Oh, wow. So if you can physically get it out, you can genuinely save them?
Exactly. Long-term survival outcomes are actually not negatively affected by the need for vascular resection. It proves that aggressive en bloc surgery is highly justified.
Okay, so knowing these complex resections are worth doing, how exactly does a surgical team pull them off? How do you cut out a piece of a major artery without starving the patient's limbs or organs of blood?
It takes incredible intraoperative tactics. The primary goal is to minimize vessel clamping time. The ischemic clock, the countdown until tissue starts dying from lack of oxygen, starts the second you clamp that blood supply.
Here's where it gets really interesting. It's literally like changing a tire on a car while it's still driving down the highway.
That's a great way to picture it. And it starts with preoperative planning. The team uses duplex scans to evaluate the patient's own native veins, like the saphenous vein in the leg or the internal jugular. They want to use autologous substitutes if possible.
So using the patient's own tissue to avoid immune rejection.
Right. And once in the OR, the golden rule is that clamping and sectioning are saved for the absolute last stage. You dissect everything else first.
But even saving it for last, you still have to sew the new vessel in, and that takes time.
It does, which is why they use specific tools to keep the blood flowing. For carotid reconstructions, they use temporary shunts, like the Pruitt-Inahara shunt.
So just a temporary internal detour too?
Exactly. You place it inside the vessel, bridging in the gap, so the brain keeps getting oxygen, while the surgeon carefully sews the permanent reconstruction around the outside of the shunt.
But what if it's a massive central vessel, like the aorta or the vena cava? You can't just slip a little shunt in there.
No, for those, surgeons construct temporary or permanent bypasses using synthetic grafts made of PTFE or Dacron. They are biologically safe conduits that route blood around the surgical field. And for venous reconstruction, there are actually cryopreserved homograft banks.
Wait, like tissue banks specifically for veins?
Yes, they store donated human iliac veins and inferior vena cavas. The freezing process strips away the antigens that cause rejection, leaving a perfect biological scaffolding.
That is unbelievable. And obviously this kind of surgical choreography isn't happening in a vacuum. It requires a massive multidisciplinary effort.
Absolutely. The vascular surgeon works across almost every oncology field. Take orthopedics, for example. With large sarcomas in the limbs, veins actually collapse before arteries do, simply because they have thinner walls.
So blood pumps in through the arteries but can't drain out through the crushed veins.
Exactly, causing massive swelling. And for highly vascularized bone tumors, like telangiectatic osteosarcoma, interventional radiologists will actually do a preoperative embolization to block the blood supply before the orthopedic surgeon even makes a cut.
To prevent fatal hemorrhage during the bone surgery.
Right. And we see similar multidisciplinary needs in urology. Prostate tumors, which are the second most frequent cancer in men, and massive kidney tumors, they sit right against the aorta and vena cava. Urological surgeons have to have advanced vascular suturing skills because the risk of tearing a major vessel is so high.
And it's not just open surgery either, right? Endovascular innovations are huge here.
Huge. We're treating cancer from the inside now. Take SERT-selective internal radiation therapy for highly vascularized hepatocellular carcinoma in the liver.
Right, liver cancer.
Since it can't always be safely removed, they thread a microcatheter directly into the tumor's specific arterial feed and deploy radioactive microspheres. It's a targeted nuclear strike from the inside out.
Man, that is brilliant. And even in palliative care, I was reading how they use stent angioplasty.
Yes. For patients with massive pelvic masses that are crushing their iliac veins, causing agonizing leg swelling. They can navigate inside the compressed vein and deploy an expandable metal stent to prop it open. It significantly improves their quality of life, even when a cure isn't possible.
It's incredible. The vascular system really is the battleground for cancer progression.
Right.
Synthesizing all of this, mastering that interplay between tumor biology, coagulation, and vascular reconstruction is just essential for any oncology professional today.
It really is the foundation of modern, comprehensive cancer care.
Okay, to make sure this sticks, let's do a quick clinical exercise for you listening. Imagine you have a patient presenting with an unexplained deep vein thrombosis in their leg, and a duplex scan confirms the clot. Based on our discussion, what are the top 3 primary malignancies you should consider screening for, and what historical sign are you observing?
I'll give you a second to think. Okay, the top 3 are lung, pancreas, and colorectal cancers. And that early warning indicator, that is Trousseau's sign.
So what does this all mean for you? It means you have to start viewing every single cancer case through a vascular lens moving forward.
And as you do, consider this thought to mull over. As endovascular technologies and catheter-based therapies become even more microscopic and advanced, could the future of cancer surgery shift entirely away from open en-bloc resections? Will we reach a point where we treat tumors exclusively from the inside of the blood vessels they rely on to survive?
Just cutting off their life support entirely from within. It's a fascinating thought. Well, that wraps up our deep dive today. Keep asking questions, keep looking closely at the mechanics, and we will catch you next time.